Hi, my name is Peter. I'm an emergency physician from Denmark working in Stockholm, and today I want to talk with you about a topic that you may be very familiar with, or depending on where you work, may not at all have been exposed to. It's major incidents and pre-hospital emergency medicine, and also a bit of transport medicine. Um, this is not this is far and beyond. It's not my area of expertise, but I just did a course in it, and I've done several courses in this topic in this area. Um, so everything I say in this lecture, please take it with a great grain of salt. It's also very local, like guideline specific for Stockholm. I'll be using Stockholm as an example, but as far as I can understand from different courses and some podcasts on the topic and so on, I find that a lot of these local protocols in different countries are quite overlapping. Um, so please use this as a low yield example where I will delve into how major incidents and pre-hospital emergency medicine can be handled. Um, Depending on where you work in Scandinavia, you may or may not be exposed to what you might call pre-hospital emergency medicine, where a doctor is in a car pre-hospitally and may or may not do some interventions before the patient comes to the hospital. Retrieval medicine or pre-hospital medicine, many different names for this. In Denmark, it's mainly anesthesiologists, or I think only anesthesiologists still, that are driving these cars. Um, but in Sweden and maybe in Norway as well, it's emergency physicians with it's either emergency physicians or anesthesiologists who are driving these cars, and different setups in different European countries. So this may be relevant for you, or it may not be at all. But in the European curriculum, this is part of what we need to do. Major incidents, on the other hand, is something that we all need to be able to at least have some kind of grasp of how to handle. All of us who's been working in healthcare the last couple of years have been through COVID, but here I'm not going to talk about COVID, thankfully, but I'm going to talk about the more acute and episodic major incidents, and especially like where you can find some references and some tips from the different experts in this field. It's one of these things that you can never become an expert in by experience, because unless you're a military or you actively seek out these incidents, such as Médecins Sans Frontières, MSF, or something like that, right? So without further ado, let's go into this lecture. And I will again advise you about my lack of experience. This is not my area, but I felt like there wasn't a lot of stuff, especially in Scandinavian countries, on the internet about this. So I figured that it may be of big benefit for people getting introduced to this topic from an emergency medicine standpoint. Um, and and so my instructions are not as granular as they usually are. I cannot get into as much details as I usually will, but use this lecture as a stepping stone towards all the different references that I'm delving into, and then you can go on and explore yourself. All right. I have to thank the Ambulance Sjukvård ASAP in Stockholm, one of the companies which are owned by the state, as I understand it, and they're becoming the only one in a few years in Stockholm, as I understand it. And they are the ones who do this course that I've just participated in, and yeah, it's a great course, so you can definitely do that as an introduction course for this area. All right, so first things first, as always, references. So for pre-hospital care, there are like one of the best references are the Sydney helicopter emergency medicine service, Sydney HEMS. They that's Cliff Reed is one of their proponents. He's working there, and like the St. England's, a few people from the St. England's team, like Natalie May, has also been working there. So you can go into their blogs, check out their guidelines. They're one of the like forefront runners in this area. If you want to like have the cutting edge there. Though it's very particular about helicopter service, and it might not apply to your specific circumstances. There's lots of blogs that go into this pre-hospital care, like St. Emlyn's Stimulus podcast, especially with Rob Orman, do some great podcasts on this. For instance, this one. There's a huge overlap between pre-hospital care, major incidents medicine, and then like military medicine. And here are some good podcasts about just military in general. And then Prolonged Field Care Collective is like a more is a medicine military pre-hospital podcast. I've in red I have shown you the ones that I think are really good to delve into if you want to. For SMAC, there's this like these great lectures by John Hines that are for everyone, but because they're really interesting. But John Hines was this anesthesiologist who died sadly a couple of years ago, but before he died, he made this huge impact in the foam world, and had some great lectures, among other cases from the races, where he talked about how he races motorbikes, and he was the doctor who came for these very very high acuity incidents with high speed collisions in motorcycle crashes in these races in Ireland and the British Islands. So very much worth seeing, and he has great tips on pre-hospital care there for trauma. A few studies that came out, just for, these are like a bit cherry picked, but just for references, that there are some great trials coming out about pre-hospital care. There was the refill trial that kind of told us that blood pre-hospital probably wasn't as important a thing as we thought it might be. And the recent UK Reboa trial, which was negative, even though the Reboas that were put in were not. I think it was a failure rate of 50% or something like that. So there's lots of things to discuss here, but just wanted to show you two studies that are out there right now and are important. Oh yeah, sorry, and then also, as always, the tranexamic acid lectures, literature, always interesting to delve into that. The best way to do that is either check out first 10EM's blocks or this Journal Jam with Justin Morgenstern and Ken Milne. All right, moving on for like catastrophes or major incidents. There's this great resource from the NHS in the UK where they have like, this is the document to read in this area. EMKs have made a podcast on the major incident medicine, and if you're specifically looking on what you call CBRNE, which we will delve into, like a few details on that. If you want to look up chemical agents, then you should check out this MSB homepage, where you can search for every specific agent, and then you can kind of find out what to do with it and what is the how dangerous is it, and so on. For Scandinavia or Sweden in general, for pre-hospital medicine, but especially major incidents, I have put out these. Actually, these are only Swedish. I haven't put out the Danish ones, but there are Danish ones as well. But since I'm working in Sweden now, and this is the only country where I had education in this area, because in Denmark I would not get education in this, as as anesthesiologists are usually taking care of this area. I've only posted these. All right. A few more. CBRNE, which is chemical, biological, radionuclear, and explosive exposures, pre-hospitally usually. Um, um, a few links for that. And then of course you have typical pre-hospital areas like burns, hypothermia, drowning, where I have some references here. I have skipped trauma. I will do at some point. I will do a big trauma video, but that is for another time. But there's a lot of great trauma literature out there, and I bet you know about that as well. Here so it's always nice to hear some of these stories. Just like anyone who's been through this the last couple of years have made some kind of podcast about it, at least, and some of the best ones are like especially this one from the Paris bombing. I really love that. And there's a few others here, from the one from Stockholm, and there's a Beirut one as well. And there's a long list here. I could post many more about these. There's also the Manchester attack, where Simon Carley, who has the St. Edmunds podcast, has made a lot of blogs about that. There's lots of things to find, but mainly I just wanted to post these to say that it can be good to hear from the point of view of the people in the situation, and what they have, what kind of experience they had, and what kind of takeaways they have. And what you will find is that even though there are definitely differences depending on the event and the healthcare system in which it's happening, a lot of it there's a lot of overlaps as well. So yeah. All right. So moving on to a few like just in general tips from a pre-hospital or major incident perspective. So in general, some of these tips that I got from the course, and I've gotten from these different podcasts and these resources that I just showed you. I've tried to like put up just 10 tips, and these are not this is not a exhaustive list. There are many more, and this lecture I've had to do quite fast and to give it quite fast, so I haven't had too much time to think about all of these. So there might be a much more eloquent way to present these, but here goes. All right. So first of all, it's really important to prepare, just like in normal emergency medicine, but especially here, where when you come out, when you come out, I'm told that you don't know kind of what is, you don't know the basics, because you're in a totally new environment, right? Lots of things that you didn't expect, such as you're sitting in front of the patient and you want to put in an IV line, but it's raining, so it's wet, so it won't, like, when you want the sticky tape won't stick. You cannot see anything because you don't have a flashlight. It's cold, so the patient is getting really cold and wet, and so lots of things that you have to prepare for, and are unexpected. So like there's like this entire thing about simulating and trying to remember, or trying to practice this before it happens, both the major incidents, but also the normal retrieval pre-hospital medicine, is really, really important here, because the situations are unexpected oftentimes, and you need to, like, you don't, just like in emergency medicine, you fall to the level of your training, right? So if you haven't trained, you will fall through in these incidents. You will fall back to what you know, and oftentimes if you haven't practiced pre-hospitally, you will have a lot of problems. Also, it's really important, just from a major incident standpoint, to this was an advice from the Drottninggatan doctor, Staffan Olheden. Just be prepared. Like, this can happen. Like, so emotionally, like almost in a stoic way, kind of prepare yourself for the fact that this will happen again, and it might be you who are in charge when it happens. In my hospital in central Stockholm, there isn't a month where we don't have some kind of incident where we have to reorganize or prepare, or at least plan for that preparation. Then oftentimes it's just it's a false alarm. It's a bombing scare, or it's an explosion where we didn't receive all of those patients that we thought. But it's really good to use these events to just ramp up and think about what are you going to do. Part of the preparation is also kind of knowing what you have in your bag. Knowing like the specific patient cases that are common, like neurotrauma. What are you going to do with the neurotrauma in pre-hospital? What are you going to do when there is too many patients to actually be able to take care of them? Who's going to be prioritized first? Whether you use algorithms for that, which I'll come into later, or you will use expertise or a combination. That's up to you, but just that, so you know that there are specific types of patients, and you need to kind of know what you're going to do with these types of patients, and you need to because a lot of these solutions are quite standard once you get to the part where they're like, once you kind of can categorize the patients into these standard boxes. And then the decision of whether to stay and play, like do something here and now, or scoop and run to move out of the way and get to the hospital, depends on a lot of factors, such as bottlenecks. Can you get the patient out of the way? How the patient's condition is, how far away you are from the hospital, and so on. So if you get it, if you know kind of the typical illness scripts, so to speak, for catastrophes and major incidents and pre-hospital patients, then you kind of have your go-to managements of them, and then you can play with the factors, time factors, and the transport factors, and so on, in a much easier way. And yes, and then of course know what is in your bag, right? And know where it is and how to get it, right? Because you need to usually go 100 or 200 meters with your bag, and you don't want to bring unnecessary stuff, right? So yeah. Then point 2 here, the doctor's job in major incidents is usually casualty flow accelerator. Another tip from Staffan Olheden, who kind of saw himself during the Drottninggatan incident as a like facilitator of transport, and more so than a treater. He didn't open his bag for treating patients because there were so many resources, nurses from ambulances and so on, already doing all of those things. So where he had a role was mostly to just get patients going so that they weren't staying too long in the what you call like in the street, or like they didn't just stay and play, they actually scooped and run, because you get really bogged down with details once you're with the patient and debates, once you're kneeling down, as John Hines say, then you lose your oversight. So you need someone externally to actually get that flow going. And also, I might be paraphrasing here, and I might be misquoting. I have no intention of doing that. This is just what I've got from Staffan Olheden's lectures, and from talking with him and other incidents, doctors who's been through incidents. So I apologize if I misquote anyone. Yeah, but in general, I think there's a lot of truth to this. So as doctors, we will do specific treatments for specific patients if needed. But most of what we do in major incidents is actually getting patients to the hospitals because that's where they will survive. And only in specific incidents making them stay for some kind of treatment, because if it cannot wait. We are not supposed to be the one leading the major incidents. Nurses and other people are better at doing that, and we as a resource are better used in other ways, especially as a decision maker for flow, who goes and who doesn't. And we already been through this. Know your equipment, and you have to bring your equipment as well, which might be a basic thing, but that's really important to say pre-hospitally. When you do triage, if there's a catastrophe or a major incident, then use those tags. There's different tags in different systems. In Stockholm, we use what is called smart tags. But just kind of show, once you have triaged the patient, then make it visible for everyone else. And in other lectures I've heard on this, they want you to kind of ID the patient as well. So if there's some kind of way to ID patients, you cannot do it with your normal way, which we do in Scandinavia with social security numbers, at least not at first. So you need some way of IDing patients so that you know how many patients are there, how many red patients, how many green patients, how many yellow patients, and where is that specific patient. So you will give them numbers, or you might give them name tags or something like that, but just have some kind of system for how to do that. And we'll get into the details of this as well, about what the good and bad things are about these triage algorithms. But one of the main points I can tell you already now is that we should not be, as with any algorithm, we should not be too attached to it. We are the ones making the decisions, and we should, especially in these circumstances, be doctors and not only use the algorithms, because a lot of the patients will be over and under triaged, and we need to, once the triaging has been done, kind of upgrade or downgrade people who needs to be transported the most, and we need to prioritize the ones that have reversible conditions, even though some people may be in a worse way, or in a worse way than others. They may not have survived. They may not have survivable injuries, so they should not be prioritized in such an event, right? And we are the only ones who can make that decision as doctors in that situation. Then communication needs to be short and sweet, right? And you need to practice your, like, how to talk in a walkie-talkie, how to do commando language. Only like use to the point language. Don't we'll go into this as well, but you have to be concise. A patient with a 30-year-old patient with an A problem and a C problem needs airway management now. You don't need to go into the details, and then this happened, then this happened, then over the radio, over the walkie-talkie. And also, like, time is the main factor in these situations. So unnecessary communication is a time waster. Short and sweet, yeah. Then triage, and that's more of a general advice. It must be simple. Like, there are some of these algorithms for triaging in the pre-hospital care in the major incidents. They're so hard to figure out, or there are so many steps, and you, like, from listening to these podcasts, you will not be able to remember all this in a major incident. As Ken Milne says, we're able to, like, remember 5 things at most, but in a major incident, a situation which is uncomfortable for most people, we may only be able to remember 3 things or 2 things. So having too complicated an algorithm will just make people go by their own gestalt, and that might be a good thing. But and that's what they're saying in a lot of these incidents. The people who's been through them, these algorithms fall apart, even the simpler ones. Yeah, so they have to be really simple and effective. Then every like there's a lot of parallels between the emergency department and pre-hospital care and major incidents. And this is balance about what do I have, like once, and this is Eric Driver's point as well, like uh, once you have an incident, you need to kind of do some kind of counting of how many people are injured, how badly injured are they, like that's kind of counting. And then I need to know what are my resources, like how many people do I have right now, how many people will I be able to get, and then you kind of do a plan, like basic maths, try to distribute your resources, and try to not do things that can wait or things that are unnecessary, either on someone who is dying anyway, which is harsh or cynical, but has to be done. It has to be prioritized like that in a resource scarce environment. But also try to think about how can you manage things so that you're not taking up too much time or a person on that specific thing. And an example of that is airway management. You may, instead of doing a laryngoscopy and putting in a tube on an airway problem, you may do a front of neck access instead, because then the patient can ventilate themselves if they're awake still. And this is controversial, and but some of the experts that we talk with, they who has been in war zones, they recommended this because then you don't have to take up a person's to back the patient once you have the tube in. So they can breathe by themselves once you put in a smaller tube in the front of the neck, right? So these things we have to think about just like that. Okay, then this is another of Staffan Olhiden's points. Don't put all your eggs in one basket. There may be you can think of this metaphor in different ways, but I think the way he meant it was that there might be a second hit. Don't send all your patients to one hospital. Don't make people gather in big groups in your hospital, especially not if all of your best trauma surgeons are in one hospital. That's not a good thing. It probably should be distributed at least across an area so that a hit to that specific hospital where they're working will not knock out the entire system's resource on trauma surgeons. Yeah. And another thing about that is also think about when you're activating your system. A lot of these algorithms for what you do when you activate the system is that you take your take the patients in the hospital and in the emergency department that are not needed to be there, and then you send them home. But if they die on their way home because they had something undiagnosed, then that's part of the death toll in that major incident. That's important to know. So you have to kind of balance your sending home patients from the hospital with how big the incident potentially will be, because sending too many home will be a catastrophe in and of itself, but sending too few home, then you will not have space for the surge of patients that will be coming really, really quickly. Yeah, so it's really it's a balancing act. Yeah. Then, of course, something that is cannot be overstated pre-hospitally is scene safety, both in normal retrieval medicine, but also especially in the catastrophes. You have to do the overview, kind of what we said about John Hines. Count your patients before going down and treating one of them. and then I will go into methane, how to like kind of that's like in major incidents, the first person there will do a front through the window report about the incident, and you can use an algorithm called methane for that. And then lastly, we'll think about bottlenecks. So once like during the EMCC course, which I'm an instructor at, we sometimes do this like catastrophe incident where we will focus on communication and bottlenecks. Those are the only two things we will focus on. Bottlenecks are so important in emergency medicine, but in general also, like especially in pre-hospital care and when time is short. And we need to identify these bottlenecks, especially if they're downstream of where we are. That means that if we cannot, either we try to open the bottleneck so that it's not a bottleneck anymore, so that flow can run through, or we need to try to make the best of the time right now. If the bottleneck is unmovable, maybe it's, for instance, you cannot get any more ambulances into the area, so that the patients that you thought could be moved and therefore you didn't treat too much, now they have a problem where you need to treat them right away, right here, because that time to see a doctor at the hospital has just been prolonged for like a lot. So then the priorities shift, and what you do will shift. It's like a dynamic environment, and so you constantly have to think about these bottlenecks and whether you're using your time effectively. Okay. All right. So 5 additional pre-hospital, like just for pre-hospital care points. Again, know where you're back is really, really important. And planned. You have to simulate beforehand for the common scenarios and go through treatments. We went through that just a few minutes ago. Then you have the opportunity cost thing, and we talked a bit about scoop and run versus stay and play. Once you it's really tempting to just do everything at the scene, but mostly you shouldn't. Almost always you shouldn't do that. Especially in Stockholm or in a big city, because there's a short transport time, so your patient is usually much better off just getting in the ambulance and then running or driving to the hospital. Not only because of their time critical condition, but also because every procedure done pre-hospitally is much harder to do than doing it in the hospital, where there's light, where it isn't raining or snowing on you, and so on. So you have to weigh these factors in. They have this motto, like a lot of the doctors that we talked with on the course had this motto called good enough. You shouldn't be bogged down with details. You should do a good job, and you should be systematic, and you should know the algorithms. But on the other hand, you should not be bogged down with details, because if you are bogged down with the details, that will cost valuable time. That's how I interpret it, at least. So good enough could be is the patient you have to fasten or spinal immobilize the patient, and you kind of all of the clickers are not clicked in, but most of them are. Okay, good enough. We can do the rest in the ambulance. That's good. So you kind of do a lot of things because of the time factor. You might do them not haphazardly, but might do them so that the redundancy that we often use to treat things, we want to make them perfect, so that there's a very diminishing small chance of that they fail. It doesn't really work pre-hospitally. It's a dynamic environment where you have to secure things, but especially if there's a short transport time, then good enough is all right. Then you have this thing about opportunity cost, right? So when are you going to do more for the patient? Well, that would be when you have a long transport time, or if you're for instance, in a vehicle such as a helicopter, where you cannot stop if things turn sour, and you need to treat them. You need to have a plan for what to do in the most common scenario. So if the patient needs intubation and you have a long transport time, maybe it's better to just intubate them on the spot right now. That's what they do a lot in Australia, where they have transport times of an hour in a helicopter, where it's crammed and noisy. So you want to do all of these things beforehand, but on the contra side in Stockholm, where you have short transport times, um, and you are usually in a car where you can stop at the roadside. Not that it's a ideal circumstance, but usually you can like manage the airway until you are at one of the bigger hospitals, right? So that's some of the things that you need to think about. One of the times where you actually do stay and play, that would be the pre-hospital cardiac arrests, traumatic cardiac arrests, where you have to do things within 15 minutes. Otherwise, they have a really low chance of survival. We'll go into that. Okay. So you may think that you do intubations all the time, pre-hospital care. Actually, there's very few conditions, at least in a bigger city like Stockholm, where you need to do a pre-hospital intubation. It could be the dynamic airways where you have burns or stuff like that, or bleeding, like a penetrating neck trauma, where there's a dynamic airway that is being lost in front of your eyes. Then it might be a good idea to do it pre-hospitally. It could be the traumatic brain injuries and long transports where you think the patient are going to fall in GCS, and you want to optimally manage them during transport. But your trauma patients in general should probably not be intubated in most circumstances. So most patients do not need intubation pre-hospitally. Then you have the thing about scene safety. Like once you go into a patient's, once you knock on their door, there's a chance of them being violent, and there's a whole talk that I'm not going to go into about how to communicate and de-escalate a patient. It's really important to know that, but I can refer to the Stimulus podcast episode 1, I think. It's called Verbal Jiu-Jitsu, or the EM Cases episode 48, I think, and 52 about communication. Those are some good resources on that. But scene safety is also like, is there any electricity anywhere? And for major incidents, it may be much more than that. Just think about scene safety all the time in pre-hospital care, because it's a dangerous environment, more dangerous than your hospital, right? Then you want space. If the patient, if you're knocking on the door and the patient is like crammed in between a wall and their bed, then you kind of need to move the patient so that you can actually work with them, get a 360 surroundings, like space around the patient, so that people can work from all different areas, and you have space to work what you need to do. Then you have the environment factors, and Cliff Reed does a great talk about this 0-point survey, which I've talked about a lot. But also there's a video on his YouTube channel about team work and how they train in these like your self team and equipment kind of, and in a pre-hospital environment scenario, and especially the also like the external factors like the rain and all of these things. You need to like know that pre-hospital care is different than hospital care, and you need to prepare yourself mentally, simulate this in your head and through practices. And then of course, knowing which hospital to go to is really a complex decision making skill, and I won't delve too much into it, but let's say you have someone with an injury, and And you may have someone who had GCS 13 after a head injury, but they're also on some kind of drugs, right? Is it because of the drugs, or is it because of something else? If it's because of this, like if it's because of the trauma, then it probably should go to a trauma hospital where they have neurosurgeons. But if it's not, and oftentimes it's not, then they should probably go to another hospital, especially if they have care there from before. Like there's lots of things that can come into context here, and it's just saying that it's a complex decision which hospitals to go to. Also, if you factor in transport time, um, and like there's so many factors that go into this. So it's a different lecture, and I'm no expert in it, so I'll skip ahead. All right, now we're going into mostly major incident terminology and mostly Swedish terminology because I don't know the international terminology here. But I guess most of the terminology is translatable, and please bear with me. So in general, here in Stockholm, the system is built up like this. You have some kind of central in the middle. SOS Larm is one of them, and they have their tentacles to every part of the system, and can distribute resources as needed. There is this thing called a major incident, which in Swedish is called a särskild händelse. A major incident is an event or situation with a range of serious consequences which requires special arrangements to be implemented by one or more emergency response agencies. And I think in the Swedish book it says, kind of like, I'm reading between the lines here, but it says something like along the lines with, you need to reorganize your healthcare system in order to keep up the same quality of patient care. There is such a high volume, or potentially such a high volume of patients, or it's something that's happening from a police or a firefighter standpoint, that you need to like reorganize your healthcare system quickly so that you can get the same quality care for these patients or for this incident. Then in Sweden, they have this thing called Storulycka, which is like a subgroup of this. And this is where even though you have a särskild händelse, even you have a major incident where you have to reorganize, then when you reorganize, your resources are high enough so that the need is less than the resources, right? So your balancing scale is either in balance or on the better side of resources. On the other hand, there is catastrophe, and that would be like the opposite, where you have a incident where you cannot, where your resources are scarcer, where your needs are bigger than your resources, so that the scales are not in balance. And this is where you need to be doing like really hardcore triage to actually be able to get the best out of the situation and save most people possible. It's good to have a map, I think, about these major incidents. I haven't been able to find one internationally, so I made or I didn't make it. I didn't make this one at all, but I put this one into our PowerPoint from the major incident guideline in Stockholm. So in general, you have a what you call the skadesplats, or the place where you have your major incident. Around this area, there's a risk zone. And this risk zone can often be dealt into three parts. There can be a hot zone, which is like I don't have the definitions of the hot zone or the warm zone, but I guess the hot zone is the zone where there's the most like activity and the highest risk for people, either because of explosions or some kind of like CBRNE exposure or so on. Then you have you have the hot zone, then you have the warm zone, which is some risk, and I guess you have the cold zone where it's probably no risk or low risk or baseline risk, because pre-hospital care, as we talked about, is a bit risky compared to hospital care. But everything has risks, and that's the baseline risk that we live with in pre-hospital care. Okay. The Skadesplatz, the incident, the place of the incident, can usually be dealt into sectors. And the reason why we deal that, like they do a sectorization of the place, is so that you can have one person be leading one sector, and then they can have the responsibility of that sector. It's really logical to, like, if you have, like, this is a small place here, but if you have a huge, like, it's actually a huge place, this, right? Lots of people being injured, then you have to put in a grid, so you kind of know, okay, this area there's 40 people, okay, and in this area there's 10 people, and this area there's 30 people, and you kind of can know from the different sectors how many people have been, like, it's just a logical way. Instead of looking about on the entire area of just 400 people being injured, then you can kind of do it in sectors and cut down the problem, like a complex problem, into smaller parts. That's one good strategy to do that. So that's what you call why you deal it into sectors, to make it more manageable. From the Skadesplatz, or the place of incident, you will do what you call a sållnings or sieving triage, and you will have patients either going to a place where they are either triaged like low risk, or here where they're high risk. The low risk area has to be manned by someone, because there might, like, the triage is imperfect, and you may have a lot of people being under triaged. So you need to have someone, medical staff here as well. The patients who are totally unharmed, oftentimes, at least in Sweden, you cannot keep them. So if they want to go, they can go. Here you have some tents, and we'll go through how these tents are organized. But this is what you call uppsamlingsplatz, or the place where you put all the injured. And then you treat here the patients, like the treatment that is needed, if any treatment is needed, and then you'll try to sort the patients, what you call sorting triage. So you have sieving triage, and you have sorting triage down here, where you sort people, which way are they going, or who is going first, either by helicopter or by ambulances. You have what you call a spot for the dead. Sometimes you have a spot for the dead, but sometimes the police want you to just keep the dead on the spot that they were found, if that is ethically okay. Especially if it's like a some kind of criminal activity, then they want it for investigation, right? Then you have these two spots, which are more administrative. You have your place where the leaders are, and we'll go through what the leaders are and do. These are the green, and here in Stockholm, the green and white are the healthcare leaders. The red and white are the firefighting, or I guess I don't have a good English word for fire. They're more than firefighters. They're like räddningstjänsten. They don't only put out fires. They save people at sea. They save people at all kinds of environment. They're experts at chemicals, so on and so forth, right? So I don't have a good word for them in English, but that's what they are. And then you have the police in blue and white. Then you have down here what you call the, I guess, checkpoint. It might be the good translation in English. In Swedish, it's called brytpunkt. This is where, like, everyone entering the area, which this area is called, like, this is Skadesplatz, like where the incident is, and this is called the Skadesområde. So everyone's entering the area of this area, Skadesområdet. We'll have to start here at Brytpunkt, and then you will, by walkie-talkie, they will talk with the leading, the ones people leading this thing, and then they will tell them where to go. and how and in the beginning of the incident they will go to probably go here to be able to help people. But as the thing progresses, they will they'll have to go here to pick up patients to go to the hospital, depending on where you are and what the leaders say. I think we got all of them here. Yeah, I think we got all of them. All right, now let's talk about a bit about this area here. What are the leaders doing? So this is this is the actual picture of the leaders, and this is getting a bit complex, or this is a bit, sorry, not complex, but complicated. But just in general, the police and the firefighters, I would call them, even though it's a very they're much more than that. It's a broader term. They are mainly responsible for scene safety and for like scene safety as towards criminals especially, and or scene safety as towards fires, falling buildings, CBRNE exposure, and so on and so forth, right? Sanitation of patients, and so on. So depending on what kind of incident it is, one of these may be more leading in Stockholm at least than the other. So if it's more criminal activity with no fires, these are the ones that are main leaders, I think. And then if it's a bigger event where is more of a natural catastrophe and CBRNE and events not man-made, no criminals, these will be the ones leading a bit more. That's what I understood. But in general, we can think about these people as leaders of scene safety. Okay. The bigger structure of what they do is up here. This is from this document from MSB, which is one of these organizations in Stockholm who are responsible for this area. But in general, this is the leading structure, and this is in Swedish. But I'll just put it down into like a few headline points here. You will see that the leadership of this group, and this group, they're similar in structure, so that they I think the purpose of that is so that they can, it's very easy to understand that they like at which level of leadership you are, like almost military kind of leadership you have. And then you also have other similarities, like you have some what you call the inner leadership or an outer leadership. These are out in the field, and these are usually somewhere in the cold zone or behind, like way away from the incident site. And these will usually be talking. They have names. These things. I don't know all of the Swedish names from these, but all of these have names, and I'll go through this one in more details because that's what I know a bit more about. So if you take the sjukvård or the healthcare leaders as a example, they have the bakre ledning, like some kind of more administrative and coordinating arm of their leadership. It's usually somewhere in Stockholm. They will be some away from the incident site. This will be they will temporarily do what is called RSSL, regional särskild sjukvårdsledning, which is a ad hoc or like when an incident happens, then they will assemble. It's different chief positions in Stockholm, and they will be calling the shots about coordination of this entire activity. And then they will see to it that there's what you call a sjukvårdsledare and a medically responsible person, sjukvårdsledare and medicinsk ansvarig. And as I understand it, these two persons were the same person a couple of years ago, but now it's in two different roles, where these are out in the field. And as I understand it, sjukvårdsledare, that's the kind of the eyes and ears of this leadership, but out in the field. So they are mostly administrative and coordinating, whereas the medically responsible person, usually it says in the guideline, has at least to be a nurse. I think the phrasing of at least is kind of ironic or funny, because nurses are probably better than we are at this. But it has to be a nurse or someone with a longer education than that. And they have to coordinate, like, what is the over yielding thematic priority, medically speaking, in the incident. And for instance, in I think in Drottninggatan or other incidents, it's usually is very generic, but it says like we need to prioritize and triage patients and then treat. Like, okay, it might be generic, but then there's an assembling or there's a common ground for what we have to do. It doesn't say like treat all airways or treat. So we kind of like, so it set out a few generic guidelines on the spot that we have to follow, so we know what we're dealing with and what we're treating towards. Also, the medically responsible person is in general the one calling the shots when it comes to like prioritizing in the field what to do and what not to do and so on. And these two talk with each other, and it's kind of, for me, it's kind of hard to sometimes distinguish these two persons' tasks. But I have in the next slide their specific different tasks, and these people have a lot of jobs to do, and also this one has a lot of jobs to do. So they may they will use a lot of other administrative people to see to it that these tasks are being fulfilled. The persons up here are using what you call a tip, tjänsteman I beredskap. And the tip is like a really central person in this activating system, because they are the ones who are kind of distributing the coordinating which hospital has to take which patients, or like from a more system kind of level. And these are not medically trained. These are in Stockholm. These are, as I understand it, these are like people with a course in this, and then but then they're administrators. They're not doctors or nurses, but they're really central in this system. Then these two guys, the medical leadership, they may do like they may appoint different people to different tasks, and one of the people that they may appoint is a sector leader. As we talked about before, you can deal up the risk zone into different sectors, with a sector leader be responsible for that specific sector and how to triage and what to do in that specific sector. And then they will report back to the medically responsible person. That is really a very basic go through a run through of this leadership, and check out this and the other documents for more details if you want. And here's a list of just what they do. All right, now let's talk about walkie-talkie talk. Again, I'm no expert, but here are the guidelines down here in the left corner, if you want to check out the guideline on this for the Stockholm region. So just basically, and I didn't understand this before when I moved to Stockholm. You have when I'm in the emergency department, you have something called the rakel, which is our way of saying that there's a alarm, or there's a prior one patient coming in. It doesn't have to be a major incident. It just says rakel in the ceiling and with lights, right? That means I have to go up to the triage desk and say that, hey, I'm ready to take a prior 1 patient. And then the nurses will get a report of this from the ambulance en route, and that say they will be arriving in 5 minutes. That's how we get our report in Stockholm, and they with these prior 1 patients. So Rakel is a specific walkie-talkie channel that is only for healthcare systems, as I understand it. And once there's that's what we use all day, every day. But once there's a major incident, these different channels, I guess the police, the räddningstjänsten or firefighters, and the healthcare system, we have, like, from lowest in the hierarchy to the top of the hierarchy, we have these channels that are separate so that we don't hear each other's chatter. But there are someone like the which I just showed you, the leadership, the top of the leadership needs to be able to talk with all these channels, right? So that's what they do in the RSSL, or this top of the leadership places, so that they can speak with each other and see what is going down all the way down here, but all of us on the ground are being removed from this chatter, because this is like a one-way. Like, if you press on the button and you speak, then you're taking up all the airspace. No one can talk to anyone once you press there. So there's what you call radio sterility, I think, radio hygiene, and this is getting into stuff that I have no idea about. But like in the military, that's usually where you talk about like how to do this in a good way. You communicate on very like need to know basis and nothing more, short and sweet. In Stockholm, they say this, what you call think, tryck, tala, släpp. Think, press, speak, and then release the button. So think, you need to know what you're going to say before you're saying it. Right, what is you want to be, and actually, as part of think, you need to practice this as well. You need to practice the commando language, which I will show you in a little while. And you press on the button, and then you speak. You speak clearly. You have your walkie-talkie like a arm's length or a bit less than an arm's length from you. You don't put it all the way up to your mouth, because that will make it sound really not nice. And then you speak for a few seconds or maximally a minute, and then you release. And usually when you release, you have to indicate that you're giving the other party permission to speak, that's where the commando language comes into this, because there might be a really good explanation why we do this commando language. It's probably so that we can precisely explain to the other party that now I'm done talking, now you can talk. Right, so in Stockholm or in Swedish, you say kom once you're done with a sentence. And once you've, ambulance 30946 is at the brytpunkt, kom, you'll then end with kom. And then the leadership position may say, roger that, ambulance, blah, 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 blah. You can now go to the uppsamlingsplats. Slutkom, meaning that you're done speaking, and then the recipient can say then klarslut, or like copy that, I understand, then klarslut. Again, I have no practice in this. I've only done it for a few courses, so but that's kind of the big idea. Then you have some specific phrases that are important to know. What do you like when you're when someone's calling you and you just want to I'm here, then you say I'm listening, or lyssnar. And then once you understand something that has been said, then you say uppfattat. Usually you don't repeat the entire thing, but you you just say uppfattat, or and if you haven't understood or uppfattat, then you will say please repeat that, or kan du repetera. So an example from this reference here is when you call someone, you do it like a present, like a Christmas gift card. You're like, to here from this. So ledningspress från ambulans. No. So you don't pronounce the to, and you kind of do it backwards. To. So if I'm an ambulance going to the brytpunkt, to the checkpoint, and I want to just say, hey, I'm here, I can now go to wherever you want me to. Then I'll say ledningsplats från ambulans, or my number, and then they will say, or then they will say, yeah, okay, ledningsplats, here is the leading the leaders. You can go to whatever place you want to go to, or which place I'm signing you on to. Then, as an example here, Kalle från Lisa kom. Kalle lyssnar, again lyssnar, kom. Jag behöver nyckeln till Skolgatan 4, kom. Och sen Kalle didn't really understand, so he says repetera, kom. And Lisa said, jag behöver nyckeln, hon repeterar då samma grej. Och sen, så uppfattat, jag fattar, or I understood. Det fixar jag. And then he says, I don't have anything more to say, so I said, slut kom. And then Lisa says, klart slut. And then I'm done. And I think there's something about the person initiating, like Lisa is initiating here. She's the only one who can say klart slut, like I'm done speaking. And I'm not quite sure when does Kalle actually know when slut kom? Like I think this is just his way to saying I have nothing more to say. Then I said slut kom. And then Lisa can actually go on and say a lot more. She doesn't have to say klart slut if she has more to say. But Kalle has just, that's all I have to say. All right, enough about walkie-talkie talk. Now let's go into details about the triaging thing, because that's one of the more important things that I think that's one of the reasons why I did this lecture, because this is kind of something that we can use in the emergency department as well. Some of the ideas from here. So in general, you have your skadesplatz. The red area here is the place of incidence, right, where the catastrophe has happened. And then here is the uppsamlingsplats, where you are. These are the tents where you are picking up patients. So you need to kind of sort patients from the place of injury or the place of the incident to somewhere where you can treat them and sort them out. So the first thing you do is what you call sieving triage or sållningstriage, and you do some really basic life-saving maneuvers. And you do it in this order. First, you will get some kind of overview of your sector. Then you will and then there's a bit of discussion in this literature, I think, whether you should go to one patient, do airway maneuvers, and then tourniquets, or you should just go around and getting tourniquets on everyone without thinking. That's like the parallel way of doing it, and the serial one is like would be take one patient at a time and then do that for 15 seconds and then move on to the next. Whereas the parallel would just be put on tourniquets on everyone that you seems to be needing it, and then go on to do the triage. The triaging thing, this is what you call the sållningstriage, and I'll show you how to do that. Between this step and this step, there might be a sanitation step. I'm not sure when the sanitation is happening. It depends on, like, it's if you have CBRNE problems, right? You have someone who's chemically exposed and needs to be cleaned in some way, so that they're not exposing themselves or others in the future. And I'm not logically it would be here, that but it may be in a later place. It depends on whether you have hazmat suits on here, right? And whether how dangerous it is for the patients to still be exposed. So here you do treatment first, and then you do sorting triage, and how much treatment is being done really depends on what is needed and how much like can I transport the patient right away? Then I'll just transport them right away instead of treating too much. But if there's a bottleneck down here, I cannot get any more ambulances, then I should just treat a bit more. And it's important to say again, the doctor can always at any time up or downgrade patients depending on their triage class. So you might think of a patient who has high, like someone who's tachycardic, but often like tachycardic and tachycardic and breathing really fast. It might be just and might be lying down, but it's otherwise okay. They could just be in a emotional shock, and if you can diagnose that as a doctor, then you can just downgrade them to begin with. But during according to the triage, the receiving triage, they should be red. There's one thing that goes without saying, but might be missed in such a PowerPoint presentation like this. This is really a dangerous area, right? Like the red area is really dangerous, and that's why you don't want to be there too long. You want to get out of the hot zone, both for the patient's and our own sake, and then move to the yellow area here. Yeah, and of course we already talked about, but think about bottlenecks. That's one of the things that will be coming up as a important thing here. I just wanted to show you that this is from the English document, hot zone, warm zone, and then you move the patients to the cold zone and so on to the hospital. This is kind of the same like flow and the kind of the same areas that I just showed you. So just to show you that this is not something I'm just pulling out of my hat. It's something that actually is in the guidelines. All right, so now for a more specific example of how to do this. And again, there's so many ways to do this. No system has been proven to be better than the other. There's as I understand it, very low evidence on this area. And all of them are going on an ABC evaluation. This is something that has to be done by non-physicians, right? It has to be done by personnel, sometimes not even medically trained personnel, right? So policemen who have some medical training oftentimes, or but sometimes someone who is not medically trained at all. So it needs to make it really basic, really simple, and everyone is stressed in this situation. So really like things that you can measure quickly in a few seconds and then move on to the next patient, because you have maybe 20 or 40 or 50 patients that you have to do this quick triaging on. And while you're doing this, you will be putting on you'll be treating big C's, like things that are killing the patient within seconds to minutes, right? That's what you're going to do here while you're doing your triaging. So you'll put on tourniquets, you and compress bleedings, you'll open airways. Let's just with basic airway maneuvers that might be just putting patients in a NATO position, right? Stuff like that. So one system of doing sieving triage on the place of incident is like this. This is called the START or Smart Triage system. It's what Stockholm uses, but it's something that is like internationally made. I think from 2012, I think it was. This is so you have someone who's walking. Are they walking? If yes, then they're priority 3. And again, this is where you come in as a physician. You might have prior 3 patients that are walking but have so severe injuries that in a few seconds or minutes they will not be walking. That's when you can, like as a physician, triage them up or down. But again, this is the sieving triage is usually not done by physicians. We have not come on the scene yet. It's usually ambulance who has arrived at this point, or police. So walking, if you're walking, yes, then you're on the walking part, and prior 3. If you're not walking, then are you breathing? And this is not just like this is dichotomous. Are you breathing, yes or no? That's not snarking or anything like that. So either you have a free airway or you don't. There's no middle ground here. So free airway, yes. And if you don't have a free airway, if you open up the airway, are they breathing? If no, then they are dead. If yes, then they are prior one, because then they usually will have some kind of D problem, which makes them so severely injured that they need prior one. If they are breathing, then it depends on their respiratory frequency. And this is where I think this one is kind of crazy, because you will never know whether it's below 10 or above 30. You will just say, if you want to do respiratory frequency, you will say, are they bradypneic or tachypneic? You don't want to do ciphers at this point. And I don't know how many of you have measured respiratory frequency lately. It's quite hard to measure that in the hospital, at least. That's why you usually don't have that good a measure of it. Or at least not specifically. So you'll just say, are they breathing fast or slow or normal? And then if they're breathing in a normal rate, then you ask for the pulse. If the pulse is really high, and then again above 120, is it fast or is it slow? If it's fast, then they're prior one. If they're not breathing fast and they're not prior one, but they're lying down, then they're prior two. Again, this is sieving triage. This is really, really roughly triage here. Just wanted to show you a few more examples of how sieving triage can be done. This is a similar model for CBRNE, where the prior threes goes to if they have CBRNE symptoms, then it will go to prior two, but otherwise the same. Here's a different system from a different region in Sweden. This is from Östergötland region. And it's kind of silly, and I think this is the case. I'm not perfectly sure, but I think this is the case that different regions in Stockholm have different systems for this. So if you have not in Stockholm, but in Sweden, so if you have an incident happening across borders, or where you have to have a national level thing, then you have different systems. That's kind of, I mean, every country should, every area should probably have the same system, especially if none of them are better than the other. But that's just my opinion. Okay. This is called the SALT triaging system. I don't want to go into details, because I don't know this one. But this is a bit simpler. Either you're walking, or you're not. You're obviously in a life threat, or you wave purposely. This is really fast to sort. This is really easy. I think I kind of like this more and better, especially if there's no differences between the receiving triage systems. Then this is really easy and much faster. You don't have to go down on the ground and measure pulses and respiratory frequencies. And then you have the one from the English triage system, this great document here that I've showed you all through the lecture. They're a 10-second triage system, and they've incorporated the treatment part in their. I kind of like this one as well. Are you walking? It's kind of built on the smart system again, but here they build in if they're bleeding and so on. So are you walking? Yes or no. No. If you have a severe bleed, then put on tourniquets, and then you're PR1. If no, then you're talking. Are you talking? Then yes. Do you have any penetrating injuries? If yes, then you're prior one. Again, a lot of these up here walking, they might be soon be these patient prior one, because they might be lying down soon. And are you talking? No. Okay, well, are you breathing? Yes. If you are breathing, then place in recovery position. If not, then you're not breathing. And CPR if resources allow, right? So, and a traumatic cardiac arrest, or like bilateral thing of thoracotomy, try to get an airway. And if you're heroic, then try to do a thoracotomy. and put in IV lines to get blood. That's the things that you have to do. That's a resource intense thing, and not achievable in a low resource environment. But I kind of like this one. I think this is a upgrade from the Smart. I think it's more logical. I think there's lots of there's no, you don't have to go down and measure things. That's a really important thing here. Still, it's like a lot of steps, and like you have to practice it a little bit to actually know it and do it quickly. But I think it's manageable. Okay. All of these receiving triage systems are kind of like, you could just use Gestalt. I like this. Like, it has to be as I said, as simple as possible. Okay, then we get to the TENS, the Uppsamlingsplatz. We have, and as patients are flowing in, we have these TENS. I think they were called FSP TENS. I'm not quite sure, but you have there's this this Danish book from a Danish legend in military medicine called Finn Warburg, and he's made a biographical book. I've seen him talk. He used to roam in the Prehospital and has a PTSD section there for ex-military patients or persons, and a great guy, I think, and a lot of has like been really good and done a lot of things, good things within this area. And I think he talked about how they developed some of the thinking about these kind of TENS, and now they're kind of standard to use these TENS in all of these major incidents. So from what I understand, sorry, this is just an anecdote, but I think he was one of the ones who actually came up with this idea in the maybe 70s or 80s. Okay, so what you do here is that you have inflow, this going from left to right, right? You have this middle ground here, this red carpet. Sometimes there is a red carpet, sometimes there isn't, but keep clear of that, because if you're not clear of that, then you have no line of sight, and you'll not be able to intubate patients if you need to. Because if they're lying with their head here, then you cannot intubate them. If they're lying here, but there's a lot of other stuff here, then you cannot intubate them. 360 space or get space, right? All right, so you have people coming in here. They've just been Solnings or sieving triaged, and then they come here and they are lying here. And then you kind of want to pick those who actually need to be treated, and then you're kind of moving them forward. I'm not quite sure how this works in practice, but you kind of have to like move them a lot, and I don't think that's that practical. But I'm not quite sure. But this is what they showed us at the course that they were doing. So you place people, and then you have a treating area where you treat them with intubation or chest drains or whatever they need. And then you're doing the sorting triage, where you have to sort which ones are the ones to go. This one might be dead or near dying, may have burns all over their body, but still breathing a bit. They are not salvageable. They need morphine and then to be put aside in a human and ethical way, right? So that some other person with a reversible or at least manageable condition can be treated. And this is really hard. It might have been a child, and this might have been an older person. Not that you have to weigh in a lot of factors for how likely it is to that patient might survive, right? So okay. So how to do the sorting triage? Well, one way of doing this, it's you have 3 parameters: GCS, respiratory frequency, and blood pressure. So, for instance, if you have a patient who has GCS of 6, and they have a good respiratory frequency and so on, then they'll get 10 points, right? On the other hand, if you have someone who has GCS of 15, respiratory frequency of 30 or above, of 10 to 29, but you have a low blood pressure, you might also get 10 points. 10 points is prior 1, 11 points is prior 2, and 12 or more are prior 3. Again, here the doctor can up and down grade patients. One that might be unsalvageable may be in prior 1, so they will be prior 3 suddenly. Okay, so let's just take one patient here, and see. This is from the Maxim, a way it's. I think it's a. I've done a Maxim course, and I think Maxim is this copyrighted thing where you can, where they made the system. I think these cards are from the Madrid train major incident a couple of years ago, and then they have all the injuries, and you can check out like what the position of so let's do a sieving triage of this patient. So what is the position? Well, they're walking. Okay, so walking. Are they breathing? And you can check out, okay, there's a threatened airway, but they are breathing because they have like a breathing here. So they have a threatened airway. That means that yes, they are breathing, even though it might be not be. So in a little while, according to this system, we'll just strictly go by this system right now. They will have to be, they will go down here. Yes, they are breathing. Then it depends on what the respiratory frequency was above 30. That means that prior red. You don't have to go in, even if they did have normal breathing, they have a high pulse as well. When I'm doing my sieving triage, I'm not looking at the patient's injuries. I'm just looking at their parameters. And you may be that's one of the problems with sieving triage. You should not be bogged down with all the details here, right? You have to tourniquets and airways, and then you have to triage them in a quick manner, right? And I think in one of the podcasts that I've mentioned from episode 58, I think from Rob Orman, they're talking about if the patient have a pulse and they have a GCS of motor GCS of 6, and they have a mortality of below 1 or 2%. Right, so those are two quick criteria as well that you can use as a triage once they come to the hospital, for instance. But according to this patient would be prior red. But it's not because of their threatened airway. If they were breathing normally and they had a normal pulse, but they had threatened airway, a doctor might say, oh, this patient has a deep problem. Otherwise, they wouldn't have a threatened airway. Otherwise, they might have a burn injury or some kind of dynamic airway. This is a problem, and they should be prior 1, not just 2. This patient is, but in this case, this patient is actually walking. I missed that. As this patient is walking, they're actually prior 3, even though they have a threatened airway. They have a fast breathing fast, and they have a high pulse. And if we then go to, if this, let's say we, as a doctor, said, oh no, this patient actually do have to go to the TENS. This is not a patient that you send to the walk prior 3 kind of area. Because, okay, clinically we think there might be a pneumothorax here as well. Okay, then we'll put in a chest drain there. That might take, or you not the chest drain, but you'll do a thoracostomy, sorry. I think your thoracostomy, and then all of these, like the symbols here are on another sheet. I don't want to show those, but in general, the patient has some minor injuries and burns. Minor injuries, wounds with exit and entry wounds, pain here. Pain here, and severe pain here in the neck. Some this threatened airway might be some kind of bleed. So pneumothorax here, that could be solved pretty easily with it. But the problem is in the field how to diagnose this. You have to diagnose it clinically, right? That's hard. But you have to make hard decisions quite fast there. So, okay, let's go to the sorting triage. And once we've treated the patient, what are we going to do then? This patient has a GCS of 15, respiratory frequency of above here, and a blood pressure of above here. So this would be 4 plus 4 plus 3, which means 11. This patient would be a prior 2, and depending on your mix of other patients, it might be right. But this threatening airway is kind of a problem here, as when we look at all of these things as well. So even though we do help them with their pneumothorax, we probably might need to do more stuff. And if this truly is a scenario where they are prior to, this might be one of the patients that you want to intubate on the spot before the dynamic airway turns bad. You also want to spinal immobilize this patient, right? Okay, so that's how to do the triaging and what you kind of are going through if you do courses in this and doing simulation in this. This is what you are practicing. Just to show you, this is from the EM3 block. Again, I put in some pictures about this is the sieving triage, very much like the one I just showed you. The only difference is that they didn't use pulse; they used capillary refill time. Doesn't matter which one it is. There's no evidence for one or the other, but I like things that are less complicated and take less time. So maybe CRT is better. And then here's the sorting triage, the exact same thing I just showed you, where you sort patients on a line and see which one goes first. Okay. So tips for triaging. As we talked about all the way through, this is only a tool. If you're an expert, a medical expert, then you should not only be using this tool. You should be using your mind and your clinical skill. And as we just saw with this patient that I just showed you, they can be in a much worse way, even though they're prior 3. So you need to think and look at the injuries as well, but not during the sieving triage. It's during the next part of the triage, and that means that some of these patients, if not sorted by doctors, but if you go strictly by that sieving triage algorithm, then these patients will end up in the walking area, which may be far away from the treatment tents. So that's why you always have to keep medical personnel on the prior 3 area. Okay. Doctors should be able to up and down triage patients. Yes. Again, yeah, and the patients are usually downgraded. I didn't show the color blue. The color blue is usually used for patients that are either dead. The dead patients are blue, but you have patients that are red, but then with a hint of blue, meaning that you cannot actually, with the risks you have right now, treat them. I think they, in the course that I just went to, they wanted us to, if you have a red card with that patient's name on it, then you will have to like bend it a little bit, so bend one of the corners or fold one of the corners. And that means that, okay, this patient is red, but they're out of, like, with the resources that we have right now, they cannot be treated. They need too many resources, they're unsalvageable. Then they will be put like that. And then once the resources, like this is a dynamic scenario, they may suddenly become treatable once ambulances or more resources come into play. And then you can bend up that corner again and then make them treatable. Okay. Usually the ones that are downgraded are the patients who have triage red but are low chance of survival. That might be burns more than the 100 rule. A rule of thumb that we were told is the age of the patient plus their total body surface area burn, second or third degree burns or deep burns, right? So that would be, so for a 40-year-old, they can only have 60% burns until it's unsalvageable. Someone the age of 10 would have 90%. Someone above 65 or 90 years of age would have, like, 90 years of age would only have maybe 10 or 20%, right? That's the rule of thumb. If it's above 100, then you're in really bad prognosis. Severe head injuries with airway problems, despite basic airway maneuvers, are really hard to do anything about. In the field, you need to intubate them, and you need to do something now. And oftentimes that's too labor intense to actually do anything about. depending on your resources. The patient that you are upgrading, for instance, the ones that were walking that I just showed you, in certain triage systems, that patient, even though they were walking, they had penetrating injuries to the thorax, they will be a yellow or red patient. So patients with dynamic injuries, even though they're up and walking right now, they will be soon. They could be upgraded to yellow or green. Yeah, and then triage versus treatment is a balance. Of course, the more resources you have, and the more like if ambulances are coming in, then and there's a short transport time, then you just want to get the patients out of the way and get them going. This is where we have to facilitate this transport as a doctor. I think we need to make things going. You need to treat on the way instead of staying and playing. You need to scoop and run and do minimally. But if suddenly there's bottlenecks and you don't have any ambulances, then you have to do more, right? That's what, yeah. So that's the thing. And yes, we talked about in the receiving triage, do tourniquets and airways. And the tourniquets we haven't talked about. Like you need to first of all put it on in the way that you want to, in a good way. You can watch videos on how to do that. You can put it over clothes as well. Put it high and tight, meaning that you need to put it proximally, and you need to reevaluate. Like earlier, you the guidelines said that you cannot remove a tourniquet that has been put prehospitally. That is now gone. You need to be able to reevaluate as soon as possible, because you're putting on tourniquets just to be sure to begin with, right? You're sieving. You're not doing detailed work. So yeah. And children, we haven't talked about children yet so much, but children are in most systems being over triaged because of their vitals are usually like much worse. At least according to the SMART system, the SMART triage system, they will always have a pulse over 130. They will always have a respiratory frequency over 30. But that's maybe a good thing. Like children should probably be over triaged, if any group, right? I think most people would probably agree on that, just because of the human side and also their survivability and need to be urgently taken care of. So I don't think that too many are arguing with that. Okay, then treatment tips. These are just a few treatment tips for that I wouldn't have thought of if I hadn't gone through these courses. So that's why I'm sharing these. So for pain relief, ketamine, and that's kind of obvious, I think. The downside though with ketamine is that it has a short half time. It's really effective, but it has a short half time of maybe 15 minutes, meaning that you have to do repeat doses. And if you do repeat doses, then you are at high risk of getting into this K-hole kind of thing. And that's not a problem if you're want to sedate the patient, or dissociate the patient later on. But if you don't want to dissociate the patient and you only want to give them pain relief, then this is a problem, because depending on the scenario, when they're going into their K-hole, they will become very anxious. Like it's a trip. Ketamine is kind of like giving them a trip. And if you're in a noisy, stressful environment when you are entering your trip, then you will have a bad trip, or more likely to have a bad trip. So it's important that someone is staying with them if you're giving them that kind of dosage, and then talking them down or talking them through it, right? And that's quite resource intensive. So for short amounts of pain treatment, then this is really good. Or short times of treatment, this is really good. But usually you will combine it with an opioid. The risk with combining it with an opioid is that they may lose their airway, but that might be a good risk benefit for most patients. The upside is that it can be given in any way possible, like IV, peroral, intrarectal, or per rectum. It's very effective. It's safe because they will still be breathing even though you give them too much, and it can be used for intubation. So lots of good things about ketamine, and I was told that you have like S-ketamine and you have ketamine, right? So the thing with S-ketamine is that it's usually marketed as being double as potent, like it's you need half the dose of ketamine in S-ketamine. Like, so if you need 100 milligrams of ketamine, you need 50 milligrams of S-ketamine, and you might have less K-hold side effects. That's the marketing thing about it, at least. But some of the experts that we talked to said that there were just like with tramadol, different people metabolize S-ketamine differently. So some people may need way higher doses than what you think, or less. And it's much more predictable with ketamine, apparently, according to that's expert opinion. That's not evidence. It's just expert opinion. So you can check that out in the sources yourself, what you think. Opioids, very good, but may lose airway. And then opioids has a longer half-life. That's a good thing. So you might combine the two, ketamine and opioids. Airway problems, well, if you're beyond the basic maneuvers, always, like, to begin with, just try to put them in NATO position. One tip we got was this thing about, well, if you have someone who is just being dropped just in front of you, you know that there's 10 more patients coming, but this patient has an airway problem, they need to get a definitive airway if they're going to survive. Let's say they have an inhalation burn. You need to intubate that patient, but maybe you don't have the resources or you don't have the time to intubate that patient because 10 more are coming. Well, then what we were advised by a war doctor was that you could consider doing a FONA instead of front of neck access, so that will be breathed by themselves. You will be removing dead space by doing a FONA. There might be a risk of them bleeding out if you hit their thyroid, but not if you're hit, like, as long as you're just doing the FONA in a normal way, with a vertical cut, not the horizontal cut to open up. Then you will be off the jugular veins and the jugular arteries. And if you don't cut too far down towards the sternal notch, then you won't be hitting the thyroid. So unless you do that, then if they don't bleed, then it's probably quite a low risk thing to do. And you have your head you have nothing else to like. What are you going to do if you have 10 patients in front of you with this problem? So this may give them a chance for survival. Tourniquets, of course, is high and tight, and we talked about reevaluation. NATO position, yes. And then we talked about the Burns rule of thumb with the higher mortality. We talked about do as little as possible in general, transport, and you have to, if you can, then treat whatever you can on the go. Yes, and we'll talk about CBRNE, but in general, if you have eardrum affection, like you cannot, if the patient cannot hear you, then there's a high specificity for other internal injuries in explosions. Yeah, there's lots of other points, but this is just like a few tips. Okay, let's try to make a major incident happen here, and then walk through the activation of it. So let's say something really big has happened. What are the steps being taken here in Stockholm? And this is where I'm not really granular here. I'm just really like big points here, and I might be missing a lot of stuff. So please bear with me. But this, like, you can fill in the blanks yourself by reading the documents. But in general, the first ambulance that is arriving, or maybe the first policeman, I think even, will be the kind of the leader on the spot until another one arrives. So the first ambulance will be the leader and do what you call a windscreen report, and you do that by doing a methane to SOS alarm. And this is in John Hines' words, like, once he arrived at a scene, you have to get the overview first. Like, you can do it by drone, or you can do it by with your eyes. but he used to count the amount of bikes and then count the amount of patients, right? If there's too many, if there's a bike missing, then there might be a patient there might be patients out of sight that are needing to be taken care of. And if you need to, once you're down with the patient on the patient's level, then you lose all your oversight. So you need to call for help before doing anything. So the first ambulance on site usually will wait with going in. They will report back to call for help before going in. And they'll do the methane. So the methane is just a mnemonic where you go through like this. Is it a major incident? Has a major incident occurred? Well, this is something actually in Stockholm that can only be declared by a higher up person, but you can, like the ambulance can inform, and during the methane, like the mindset is that the ambulance is just wishing for all of these things. They're wishing for help, and then someone higher up is responsible for activating the entire system and saying that, oh, we can give you this or this or this. But the ambulance is wishing. And the important thing is this is a windscreen report. This is not the entire thing. This is just through the windscreen. It's just quick and dirty. And then it has to be updated. But that's baked into the thing. And you need to do this in 30 seconds over the radio. So major incident, yes, the one that we just looked at looks like a major incident. Exact location, where am I? See if you can be as precise as possible. Type of incident, this is a kind of an explosion with fire, and we don't know more than that. Hazards, well, there's fire. We don't know whether there are chemicals in there. That might be updated later, right? But right now we don't know. Maybe CBRNE, but at least explosions and fire. Access points. We don't right now have an overview about access points. We will get back to that. Number of casualties. Well, we don't know. There's it's burning, and it's a high populated area, maybe. So we could think that there might be a lot. We cannot see anyone where we can hear screaming, so that might be a lot, right? So emergency services, which and how many do we need? Well, this is where we wish. We need all services. We need someone to extinguish the fire. We need police, and so on and so forth. So we should be able to do a methane. And I'm told that ambulances are often reluctant to become this kind of leader role to begin with, but we need to step off the bandwagon effect and just do what is needed in the situation. That's why I'm telling you about this as well, because that might be you. All right. Scene safety. So that was time 0. The first ambulance has arrived. Then after a couple of minutes, maybe then this kind of structure is being set up, right? This is not something that is there to begin with, but this is being set up over minutes or half hours. So this network is being set up. Once the scene is safe, then ambulance can rush in. But before the scene is safe, it's the police and the räddningstjänsten who are the ones who are taking care of this area, right? They're the experts here now. First, when they give the green signal, we can go in. Right, scene has to be safe before we can go in. Once the scene is safe, then the leaders, like the hospital leader, will call ambulances to the brytpunkt, and then they will go from the brytpunkt. They will channel back to the leader and say where would you have to go, and then they'll go either here to the skadesplats for sorting, sieving triage, or they will go and pick up patients. They will do the Solningstriage in sectors and transfer the patients to the tents and treatment here. Then once the ambulances will pick up these patients, then we'll get to the hospitals. And once you're in the hospital, and this is just really quick and dirty because my course wasn't about hospital catastrophes, but you need to look at your own local protocol. You need to practice this. And if you are in triage like I do, sometimes then you have to think about, okay, if a major incident happened right now, what would I do? And this is a great podcast going through this kind of thinking. But in general, and from like the references that I just showed you in the beginning of this lecture, some of the take-home points are: get rid of the patient deemed safe to go home. This is a balance, as we talked about, depending on the incident. Stop all planned operations, or at least pause them. And then you have to activate the kind of a chain reaction, like inform the ICU, blood bank, surgery, the people that you need to know has to be on standby. In the Manchester arena bombings, they texted out on WhatsApp groups, and we have done that in Stockholm as well, and a few incidents I've been involved in. You text your WhatsApp group, and then see, okay, who's ready to come in if you need to, and then you will be called in if you need to. So this is a really quick way to activate the system. And you start your local plan. Oftentimes it involves someone being the leader and someone being a triage leader and someone being, well, I don't know, depends on your local plan. But oftentimes it depends on, it'll be like everyone is being collected, and everyone will say like, okay, we have now an incident. Either we're waiting for information, or yes, we have information that we're going to receive a lot of patients. And according to well, the Oklahoma bombing, a lot of the other, like the Las Vegas shooting in the United States, people will be coming in within 5 or 10 minutes sometimes to hospitals that are not used to taking care of high acuity patients in that way. And oftentimes you'll be getting 10, 20, 50 patients within a very short amount of time. So you need to be able to kind of get things rolling really quickly. And I don't think a lot of hospitals are geared towards that. They talked about trauma centers and how easily they will be overwhelmed. Like 5 traumas in simultaneously, that is something that will overwhelm anyone, and also the trauma centers. So this is a situation where hard decisions have to be made, and you need all hands on deck. People need to be do things that are used to doing. Do what you usually do. You don't have to call in your dermatologist and make them intubate people. You need to make people who are like, so for instance, we need someone to take care of the patients that are already in the emergency department that cannot go home. Well, then you get internal medicine to come down, take those patients, and go up, or surgery and take those patients and go up, right, and continue with them. That's important, right? So that emergency physicians, maybe surgeons as well, and anesthesiologists can take care of this part of the job, right? You need resources usually. You need to prioritize which spaces are, like, you have prior 1 base, you have prior 2 base, you have prior 3 base, you have death base. Just like in the pre-hospital area, you need this kind of sorting also in the emergency department. You need to think about, like, over the long time, food and essential equipments specifically for this incident. For instance, if it's an explosion, or somewhere burning, like there's a fire, then you need oftentimes blood and chest drains and oxygen. So you might just get a cooler down from the blood bank right away with lots and lots of blood, right? You need to close down your entrances, because then the second hit will be harder to do, and you need to have guards at the entrances, right? You need to know that these things comes in waves, and I think the first 50%, oftentimes in literature, from these incidents will come within the first hour. Then I think additional maybe 30 or 40% will come within a couple of hours, and then the last one will come over a couple of hours or days. But people will be coming in not by ambulance, but they will come in by themselves as well. So they'll be coming before sometimes you have the incident report, right? Depending on how close your hospital is to the incident. So you need to be ready right away and be able to scale this up really fast. It's important to say that this is one-way flow. So if once the patient has gone to CT, they will not go back to the ED. They will have to go somewhere else. because there's too many people coming in. You cannot get patients back. And the system should be built towards that. Then it's important so that, as I said, there are several waves, and this will create a ripple effect that will last for days, maybe months or years in the healthcare system. As we saw with COVID, but that was a special long-standing incident. But even shorter episodic incidents will have lasting effects on the healthcare system, like ripple effects, butterfly effects for at least days and weeks and often months, because of all the pausing of the system and so on. Right, the entire system is shocked in some way. So you need personnel not to come in right away, but you need to tamper or and like deal, like sort out your resources over days and weeks. Personnel don't need to come in right now, even though it's exciting to be in a major incident, right? And some might really want to be there. It's important that they rest so that they are capable of coming in tomorrow and the day after tomorrow and so on during hard circumstances. Okay, and it's important from the Oklahoma bombing, when I saw one of the chief surgeons during a lecture in Copenhagen about that, he talked about a lot of the staff might have family members that are part of the incident, and you need to take care of, like, that's just a reminder of the psychiatric and psychological impact that this may have to anyone involved with these hard decisions, but especially patients people who have their own mother, father, brother, whatever, in the incident as a patient, right? So you need to think about what to do if that happens, if someone breaks down from that. And then, at least in my emergency or our emergency department, it's not staffed by emergency physicians most of the time. We are a few emergency physicians, but most are primary care physicians who are doing a rotation or interns or lower rank than that, and then may have to be explained what to do with your burn patients, or explained what to do with your burn inhalation, or CO inhalation patients and cyanide intoxications, right? So you might need to do a small huddle where you just say, this is a treatment that we are going for most patients: oxygen, like cyanokit, do a VBG, do a urinary pregnancy test if they're younger, and then do a neuroscreen. That's it, something like that. So they kind of know what to do, and then do your own small triage model. This is just to say that there are models for how to triage patients in the ED. I won't go into these in details, but you can check out it yourself. Then transport medicine. So just a bit about how to transport patients, not only from like a site to the hospital, but also from the scanner. From the emergency room resource bay to the scanner and back, right? Every time we want to transport the patient somewhere to somewhere else, we need to think about these things. So you can think about this as there's a primary transport and there's a secondary transport. Primary transport is a new case from one area to the other. Usually it's from pre-hospital to hospital, but it can be a patient on the ward where you have to call your MIG, a MIC team, or some kind of anesthesiologist, where they become worse and you have to transport them to a ICU, for instance. That's also primary. Then you have a secondary, where it's from one hospital, like it's a semi-stable patient that needs higher complexity of care. So or maybe they have to be transported from a tourist destination outside of your country to your own country. That's also secondary, like from hospital to hospital. It's important to know that not only from, it doesn't have to be only hospital, like transports can be from intra-hospital as well. And for emergency physicians, this is from, like, especially from the resource bay to the scanner is really important to think about. There's always opportunity cost in this. Sometimes you cannot prepare too long, because if the patient is really in a bad way and it's really short transport time, like we have our neurosurgeons almost just down the street. So if we want to treat them fast, then we probably need to get going instead of staying and playing, right? So sometimes there's a balance between preparation and opportunity, like risk of waiting. And it's important, like patient usually needs more sedation when they're going outside and when you're moving in an ambulance. So you need more sedation, that means more vasopressors, right? So you need to prepare for all the things that need to happen. So first of all, you need the basics, right? Where are we going, for how long, and so on. And what mode of transportation are we doing? Like, is it air? Because that's a special circumstances thing. Or are we doing by car and so on? And do we have all the information on the patient, like an S-bar? And also in Stockholm, we're using different computer systems, right? So I might need to write like to do a printout of all the information for the next hospital, so they know the medication list and so on. And then the pre-transfer, you do kind of your pre-transfer assessment. Life in the Fast Lane have done a lot of things about this, and you can also look at an example of a checklist that you can use here. And in the next couple of slides, I will show some examples of checklists as well. But in general, you can go through the A, B, C, D, E's, like, okay, A's, do they have a safe airway? If not, are we having like a long transport time? Then maybe I want to secure that airway if they're critically ill, right? B, do they have monitoring? Do you have the equipment to treat at a B problem if needed? That might be chest drains, that might be oxygen, that might be, I don't know. Yeah. C, do you have lines on the patient? Do you have vasopressors? D, do you have neuroprotective things in place? Do you have sugar? Do you have all of these things? Like E, are they hypothermic, or can we, like, are they normal temperature? That's the thing in general in pre-hospital care. They talk all about it, like keep the patient warm, because then they will not develop the lethal triad, or they will be a lower risk of developing it if they bleed. So in general, just keep the patient warm if you can. And so on. This is just a quick run through, like, what do I need, right? And you can do it in different ways, like equipment, like ST, self-team and equipment, and monitoring, and so on. And what is the potential? It could be a good idea to like do a sign-in or a brief of your patients, of your team. So this, which scenarios might you think about, like, what are the likely scenarios and what are we going to do? So usually when I go from the emergency room or the resus bay to the scanner, I will usually say, if the patient has a heart, like if they have a cardiac arrest, then we'll do X, Y, and Z. If this happens, if the patients are going into seizure again, then we'll load them with Keppra or levetiracetam, and then we'll go straight to the ICU or straight back to the. So you have a plan for what happens if this happened, then that, just for the most likely scenarios, right? And that also informs you what you want to bring in your bag to the scanner. Okay. And then just really shortly about it. It's a bit different when you have to transport patients by air. I've never done so, but I've had some lectures on it. And in general, there's a great link down here. But in general, what happens, like really basically, the FiO2 goes down as you go higher up, and the air expands. So everything which contains air or fluid, air or fluid air surfaces, you'll need to think through that, and you might do that through a checklist if you're unused to it. I would have to do that, but you might think of materials such as your cuff for your intubation tube, right? If air expands, then it might blow up, or you might get so you have to take out air once you go up, and then you have to put that air into it again once you go down, right? That's just one thing. If you have a cast around your leg, then that might expand, and the other expansion might lead to a compartment syndrome. So you need to open it up once you're going up, and so on. Some patient pathologies may also change, right? So if you have someone who has a stable pneumothorax, that air in the thorax will expand, and that might that will give you a problem, right? You might like all the nitrogen in your body will also expand, right? So that might begin to bubble, and that means that you might get the bends if you've been diving, and depending on how long and how deeply you have been diving, then you might not be able to fly at all. And if you have a diving certificate, you will learn about all of this. But it's just something to think about as well. And then of course you have limited space, right? So, and you cannot stop usually. So if you want to know more about like this and how to be an expert at this, then I suggest checking out Cliff Reed's videos on this, and checking out Sydney Hem's homepage about these things. Here's a checklist that is really useful for transport. Airway, B, lungs, C, hemorrhage, so on and so forth, and then just get going, right? So that's just one checklist for this. There are other intra-hospital checklists here from the Alfred, also a Australian hospital. I think it's in Melbourne, maybe. And so on. Just as a point, it's nice to use a checklist for these things. Okay, then just a little bit about being a doctor pre-hospitally, what you do once you're going in your car towards the patient. You do a sign in your car with your nurse. Do a CP, like just when you do a sign in with your team before a patient arrives in the resus bay, you'll have to do the same thing in the car. First, safety, get the space and the crowd, control it, get an overview before you come to the place, and get a worst case scenario. How many patients are injured? How many cars are there? Do the amount of cars add up with the amount of patients? Then you'll do some triaging. If there's a major incident, you'll do the receiving triaging to begin with, right? And you'll do the planning. What are the likely scenarios? What are we going to do? What are we going to bring? Where are we going to stop? And then you implement the plan. Okay, and on scene. Once now you have your overview, you've called everyone you need to call. Now you're implementing your plan here. So you do your O, A, B, C, D, E's, right? Or O overview, like are there anyone who's in cardiac arrest? Is the scene safe? And do I have protective garments on me? C, like that's what you call little c sometimes. Like, is there any major hemorrhage, major anything? That I need to be stopping? Do I need to put on tourniquets? Do I need to secure the airway really quickly before heading into my ABCDs? If it's a child, you'll use the pediatric assessment triangle or the BBB. If you do the EPALS, in short, you check the breathing. Like this is like only what you can see with your eyes. So breathing, body color, and behavior, right? I've made a video on the EPALS algorithm, so check that out if you are interested. And then again, here in the pre-hospital thing, you don't have all the monitoring gear that we have in the hospital, so you do most of the things clinically. So A is look, listen, feel. Check the breathing on your forearm, in front of the patient's mouth. Are they breathing? As we talked about, intubation is only in special circumstances. Check out the Crutzen et al. for a more nuanced take on that. That's a great article to read. C-spine, you have to do C-spine mostly if they're critically ill. Then you do a good enough C-spine. If they're not in the critically ill way, then you'll do a C-spine according to the C-spine rules and so on. Check out the algorithms coming later. On B, you don't have any saturation curve, so because it's usually cold and you don't have the machinery, so you do a respiratory frequency, and then you'll check the thorax, and then you might do an end-tidal CO2. That's a good thing to have pre-hospitally, because you can fit it on your back valve mask and give them oxygen, and then you can read it. Pulse frequency and filling is really important, and the CRT, the capillary refill time. The blood pressure is usually time consuming and usually not useful. If you do POCUS, then think about doing in the ambulance, and you can you can do it in this, like in trauma, you can do it like this. So check the heart first. You'll do it in a protocolized way, right? So when I'm checking the heart, I'm only looking at PECs. No, there's no PECs, and I'm looking at volume status. No. Okay, lungs, I'll just only check the apical views C1 and C5 on both sides, right? So to check for big pneumothoraxes. And then I'll do the fast. And the reason why PECs is important, like the heart is first, because then I can see, is it like in a traumatic setting, is it moving? Yes or no? Is there Is there PECs, like pericardial effusion? And because then I can stick a needle into it. I can do that in the ambulance. I can do that pre-hospital if I need to. The lungs as well, I can do a finger thoracotomy, thoracostomy if I need to. But if the patient has heart standstill, I don't bother with diagnosing that. I'll just go to my algorithm of cardiac arrest and trauma, where it would just automatically put in 2 chest tubes, or at least finger thoracostomies, right? Because the reason why these are prioritized or areas in focus is that these are manageable. And then I'll go to my fast. I cannot give them more blood than I have. I cannot give them the more volume that I have in the ambulance, but I can make sure that they go directly to the operating room. That's one of the benefits of doing the fast. But 2 things that you can actually change your management, just like in the emergency department, but more extreme here. One of the experts that we talked to said we shouldn't do pelvic binders regularly because they only kind of mechanically help with certain pelvics, like open book fractures, but not the vertical fractures. They might make them worse as well. So he suggested that you tape the knees together instead, because then you won't compress the pelvis at least. Usually the ambulance only carry 1 bag of blood, or the akutläkarbil. The doctor, pre-hospital doctor, only carries 1 bag of blood, and the refill trial didn't encourage us to do more, at least. So, yeah. If the patient on D, you'll do GCS, eyes, and focal stuff, and then maybe blood sugar in specific circumstances. If it's an isolated head trauma and a diamond spiral, then you will do intubation, and you will keep the MAP over 80, meaning that you'll use phenyl if you use propofol, or otherwise you'll just use ketamine. And then really, really important, keep them warm, give them pain relief, and splint them if they need to. And here's just a checklist for how to, like, checklist for what to do when you, like, before you intubate a patient. Here's some trauma algorithms for pre-hospital care in Stockholm. The one in Stockholm and the national one. So this is an application of this one, and you can read through that yourself. Here is the algorithm for C-spine precautions. In general, are they time critically? Are they in a time critical condition? Then transport takes priority over perfect spinal immobilization. Otherwise, you'll do this part of the normal algorithm. And for children. Okay, then really shortly about some of the typical cases. So one of the typical cases that we will see, or common cases, are like pre-hospital or CBRNE in these major incidents, like chemical, biological, radionuclear, and explosives. And I'll just mention a few of those in the last couple of slides. Then, of course, bleeding, and I won't go into trauma here. Neurotrauma as well, drowning and hyperthermia, and I won't go into these here. Just wanted to show you again this really great guideline from the NHS, major incidents and mass casualty events, where they, for each problem, like each illness script, they have these great pages where you can say, okay, what do I need to do, and what are during my A, B, C, D, E's are a problem, right? I strongly encourage you to check out this if you're interested in this stuff. All right, so CBRNE, specifically chemical. So chemical, in general, if you have some kind of chemical, check out your local toxicologists or this page called MSB, which is like one of the Stockholm or Swedish pages where you can get information about every agent and what to treat them with. In general, chemical can be, like, injuries can be dealt into local, inhalation, and systemic. Local is like skin injuries. Inhalation is like can be dealt further into irritants. You have irritant, like irritating the airway, like usually chloride or ammonium. Systemic, like you're being your blood pressure falls, or you might be hypoxic and therefore have systemic symptoms. That's like carbon monoxide or cyanide. And you have your inert gases as well, where you get a complete, like inert gases will compete for the oxygen in your alveoli. So they are a problem like that. That might be like NOx, like loose gas. If you breathe a lot of that, then you don't have any spaces left for oxygen and so on. The treatment is usually sanitation. You need to sanitize people who are exposed. In Stockholm, that it's good to know that you have to call SOS Alarm and the poison center to kind of know how to do that. You usually have to observe these patients for a while because the lung injury can be delayed, and it's really important to like just ask people who know about this stuff before sending them home. Usually you give them some kind of inhalation therapy, usually oxygen and some kind of medicine, usually like Ventolin and salbutamol, salbutamol and ipratropium, but a 10-time dose of prednisone inhalation is oftentimes used here in Stockholm. You might have to give them eye drops, analgesia as well, and a lot of other things depending on like the specific syndrome, such as oxygen and carbon monoxide poisoning. You might have to give them methylene blue if they have methemoglobinemia. You might, if it's a cyanide poisoning, you give them cyanokit, so on and so forth, right? And all burns are traumas until proven otherwise, so on. And here are some examples of what it might be. I'll go back to, you will get to what you call a CRESS in a few slides, and I'll show you them. Then you have radionuclear. Radionuclear is like 4 rules. In general, you should be exposed as shortly as possible. You have to keep a distance as far as possible from the source. As much stuff has to be between you and the source, especially lead. And use tight-fitting clothes so that gases that are radioactive cannot enter your body. In general, there are 3 types of these kind of radiation. There's alpha, which is really big particles that has a short distance from the source, like big balls coming at you. If you have something like, if you just distance will help you with that. Lead will help you with that, and gamma rays are these like go through everything, kind of even sometimes like even lead. So you need to just be like high distance and a lot of stuff between you and it to reduce it. You measure it by, like, if you have a patient here and you might think they're radioactive, then you'll take your dosimeter, which measures the dose, and you'll stand here and then you take one step closer and then measure the dose and then one step closer and so on until you see how high the dose is. And it's measured in millisieverts, and a dose above 100 millisievert is not that much, but it's where we draw the line for high risk for healthcare personnel. All right. Then you have something called an intensimeter as well. That is something that measures the intensity of the source, right? So someone standing 5 meters from the source might have the same, like the dosimeter might show 0, but one step closer, if it's a really intense source, then the intensimeter might go really off, and then at the other one it might not. So it depends on how intense the source is. What you do is, first we were told in Stockholm to call the hospital physician. Just a side note is that all the doctors prehospitally have this in their car, so we might as well just call them, because I don't know how to get a hold of my physicist in the middle of the night. So it might be easier just to call that doctor prehospitally. Then you isolate the patient and you do that kind of like step towards them to see what their dose is. And and you also have to sanitize them and treat them for whatever they need to be treated for. And of course you have acute radiation sickness, which is right at the source. And I don't want to go into too much about this. Then you can read up on yourself, or there are lots of great resources in this. Here comes the list of like what you call the CRES for chemicals, though. And all kinds of exposures. So it's like consciousness, respiratory, eyes, secretion, skin, and other features. And you can, and then all the agents are listed up here. So nerve agents, vesicants, which are like stuff that makes you have blisters, pulmonary agents, cyanide, and so on. There's lots of these lists, and just to show you what kind of how you can, like, from clinical presentation, kind of make up which one it probably is that has exposed the patient. Okay, then explosives. In general, you have an explosion is just energy, heat, and gas being released and compressed, I think. I'm no physicist, but it's a lot of, there's energy, there's heat, and there's gas related here. And you can there's two kinds of explosions. There's low explosive explosions and there's high explosive explosions. Low explosive explosions, they do not produce a pressure wave. They're what you call subsonic. It's just heat. That might be like throwing a Molotov cocktail or stuff like that. And then you have the high explosives, and that's what per definition creates a pressure wave or blast wave. It's also called a detonation, which is ultrasonic. And this is usually explosion from C4 or TNT, but it can also be this like ammonium sulfate, which used to be able to be bought on the internet quite easily, and I think it was part of what is the Oklahoma bombing incident. That was ammonium sulfate, but now it's regulated more. And then it's important to know that low explosives in a closed space can become a high explosive. So if you like, in general, explosions in a closed space are much more dangerous than in an open space, because the energy cannot, something about it being compact, the energy cannot be released, so it's being absorbed through your body instead. But also for explosives, if you put a low explosive into a container, then it will become a high explosive. Any child in Denmark is being taught this in school, and how not to use fireworks, because it's like one of these things where there's a lot of injuries. All right, the injuries can be dealt into five parts. There's the primary injury, that's from the blast injury, and this will hit air and air fluid zones, meaning lungs, bowel, brain, and so on. It's usually instant, but can be delayed for a couple of hours, and it's usually impacting the lungs, and you have brain disruption, and because of these things, they may induce apnea, bradycardia, and hypotension. So the patient may look dead, but it's reversible. It will just take some time before the system gets back into gear. So it's okay to start CPR in these patients if you have resources to do so, because they may only have been in shock or kind of like a stunned position. You have in this primary explosion usually what you call amputations, or a spectrum of amputations, like body parts going off, and the most severe is what you call total body disruption, where your body is beyond recognition. So the thorax is what you call blast lungs. It kills people who survive the initial events usually, and that is also one of those, like, it needs observation. So CBRNE in general needs observation oftentimes, or especially for the lung part. You have to think about the eardrums, because they're high specificity. If you have eardrum problems, then there's a high chance that there's other injuries somewhere in the body. But if you have eardrum, if the eardrums are not gone, that doesn't mean that there are no injuries in the body. So it's like it's not sensitive, but it's specific. Then you have other blast injuries such as blast brain. It's important to know that like a helmet will not help because the blast wave can come from down and up. So it doesn't have to, like, your brainstem is not protected, your thorax is not protected, so it can it can develop from your thorax and up through your body instead of coming where your helmet is covering, right? So you can easily get blast brain, and nevertheless you can get open globe injuries in your eye and blast abdomen. Secondary injuries are material from explosions. So that's what kills most people. That's shards of glass or metal or dirty bombs with stuff in them where it just flies everywhere, splinters. Yeah. And at the lectures they showed us videos or scans of people, and there's lots of things that are in people, and some of them are like biological material that might create diseases and size of infection. Other might be sharp things that has to be removed, right? It's really a nightmare for a healthcare system to deal with a lot of these patients at the same time. Tertiary things are like trauma from falling material or being thrown out through the patient being thrown through the air. Quaternary, it would be fire, gas, radiation from the explosion. And quinary, that will be illnesses years and years after the exposure, like dirty bombs, or maybe skeletal parts from people jammed inside the person's, like because of explosions. For instance, there are cases from suicide bombers where suicide bomber is dead, but their skeletal parts has been implanted in others, in victims of the suicide bombers who survived, and then they will get whichever disease are in the suicide bomber, right? So hepatitis, HIV, so on. These are real things that have happened. Okay. And also you have the PTSD part and so on. That's usually a separate part, but that's like depends on how you deal with it. What you do when they come to your department, well, do a CT scan of the entire body because you want to know where all the injuries are and where all the splinters are and so on. Use protective equipment and give them TXA and blood, and then observe them. And then we just go to the last slide, which is traumatic cardiac arrest. I will do an entire video on this later, but in general, traumatic cardiac arrest is different than your normal algorithm. It's one of these subpopulations of cardiac arrest where you have to do things differently. In general, and this is also in the ERC guidelines 2021 now, don't do compressions if you have other things that has to be prioritized more. The things that you have to be prioritizing more than compressions are your HOT or your HTT, which you have to do in parallel. But oftentimes these are pre-hospital cases, so you cannot do too much in parallel. But you'll do airway maneuver. You'll try to get a secure airway. Usually that means intubation. You'll do bilateral finger thoracostomy. And if they have a tampon, you get like IV access and give them blood or medicine, and you try to check out if they have a tamponade. If they do have a tamponade, usually it will not work with a pericardiocentesis. You need to open the chest, and that will be a thoracotomy. Especially if it's a sharp and not a dull trauma, then there's a higher chance of them surviving. All right. So if you want to look at the lecture on this, it's John Heinz's lecture called "Crack the Chest and Get Crucified." And of course, like with all cardiac arrests, the patient might have have crashed their car because of a medical event. They might have had a cardiac arrest from other causes than trauma, right? So you need to think about that as well as part of this. And the percentage I've shown here are the estimates, like the rough ballparks of how common this is in traumatic cardiac arrest. It's better, like there's a rule of thumb we were taught in the pre-hospital environment, like if like time criteria has gone out now, but our experts told us that 15 minutes, maybe 20 minutes without any activity, like or like sorry, from the last signs of life, that's a really bad prognosis if you've done all of the 4 H's, like those 2 H's and 2 T's, or the hot algorithm up here. Then you might have to stop, right? And now I'm always like, how much blood can you give into the patient before you stop? But usually they say like it's a time factor, especially if and then there's this study down here from this amazing doctor called Inabe, who's I think also a policeman, as I was told. But he does this study where it showed the likelihood of survival when performing thoracotomy if pericardial fluid and cardiac motion were both absent was 0. So you should not do of course not do a thoracotomy if there is no effusion and there's no cardiac motion, right? And the thoracotomy is especially, like most of these things, is within 15 minutes from when you see the patient arresting, especially if there's still cardiac activity. Once you've done all these things, you can go back on the chest and do compressions, but it probably won't work because unless you have any fluid pumping through the veins, right? Yeah, so I think that's what I want to say about cardiac arrest. This is just a really, really basic lecture on pre-hospital care and especially major incidents. I think this is probably what we need to know, like from a more theoretical perspective, and then you have to read your own local guideline. Please, more so than usual, check out my references here, because I'm no expert in this, but I thought this needed to get out there because I haven't seen such a lecture in a Scandinavian context. So I wanted to put this out there and just show how things are done here in Stockholm, for instance. All right. I will thank you so much for listening and see you again next time.